Thank you very much for inviting me to talk today. It's a great pleasure to be here. I'm going to reflect to you about our practice at UCL in London, that's University College in London, where we've established a CAR T-cell program really that's been driven by one of my bosses, Dr. Martin Pule. And I'm going to focus just on CD19 malignancies rather than specifically talking about lymphoma leukemia per se. My disclosures are listed. And so essentially a chimeric antigen receptor doesn't really need much introduction to this kind of audience, but you're aware of the three important components, the most extracellular portion being the antigen binding domain that can really be generated to any surface antigen on a target cell. It's pushed off the surface of the membrane of the cell by a spacer region. And there's a critical intracellular domain such that when that antigen binding domain meets target, it sends a potent signal into that cell telling it to divide, proliferate, and send out a cytotoxic signal. Now, despite all the advances with CAR T-cells over recent years, and certainly this is probably the biggest development in hematology in my clinical lifetime, but there remain some significant challenges for us in the field with CD19 CARs. Firstly, making bespoke products for individual patients is incredibly costly and it's very complex. And if we want to bring this therapy to the masses, we really need to work on systematic ways of reducing the costs and complexity of manufacture. It's already been alluded to that these are toxic therapies, and these are novel toxicities that we don't tend to see with other chemotherapies, namely cytokine release syndrome and neurotoxicity. Of course, thinking of our patient populations, the majority who are going to come through our clinic doors are going to be elderly or older, and they've got all those comorbidities to consider. So designing your CARs with the object of reducing toxicity is clearly very important. It seems particularly for lymphoblastic leukemia that a robust long-term engraftment is important in order to be able to deliver a sustained response. So technology to push that aspect further, to improve T-cell fitness, all of these are probably important to the field. And in fact, in CD19 positive malignancies, the biggest problem, or the biggest cause of relapse that we see is loss of target antigen, that's CD19 negative escape. And clearly we need some strategies to be able to address this as our most formidable problem. And of course we want to be able to deliver allogeneic CAR T, because actually making these autologous products on an individual patient basis is difficult, and also in some patients it's not feasible. So we have to work on these other parallel approaches also. So if I tell you a little bit about how we're doing things at UCL, we've got three main brackets that we're looking at. We're looking at the manufacturing of CAR T with the objective of being able to bring CAR T to more patients. We're looking at the physiology of the CAR T constructs that we're putting into the clinic. Can we make them more physiologic and perhaps by doing so improve their persistence in vivo? And we're also looking at targeting, bearing in mind that CD19 negative relapse has been one of our biggest clinical problems to date. Now, I'm going to first focus on the CARD study, which is looking at automated production of CAR T, again with the objective of bringing this therapy to more patients. Now, this is our own GMP facility here. It's one of our technicians, Gordon, in an isolator in a grade A laboratory. And this is the conventional manufacture process that we've been utilising at UCLH and UCL. And it's very cumbersome and complex and labour intensive. It requires lots of manual handling steps, and with that introducing lots of potential variability, not just in the process but also potentially in the final product. And it requires a lot of equipment that's very difficult and expensive to maintain. And really the biggest problem with this was that we just weren't able to manufacture to the ambitions of our programme. We have so many studies to service. So on the strength of this, we tried to look at alternatives, and we entered into a collaboration agreement with a wonderful biotech company called Miltenyi, and I'm sure you are all very familiar with this piece of kit. This is the Miltenyi Prodigy. And basically this really is supposed to replace this very labour-intensive open manufacturing that we've been used to. And what it is, it's a benchtop piece of equipment. It's fully closed. Rather than going into an isolator, it can be housed in a C or a D grade GMP laboratory. There's very minimal hands-on time in terms of the manufacture. It's a programmable matrix which you can operate via a touch screen. And really critically, it reduces the amount of cell manipulation steps. And by doing that, you actually improve the standardization of your product because you have less of that potential for human error. And one of our collaborators, Professor Kasim at Great Ormond Street Hospital in ICH, he performed 8 scale-up runs of donor material using this piece of equipment. And he really showed, firstly, that using this machine, you get excellent transduction efficiency, excellent CAR expression on the surface of your final product. And what's more, the yield of CAR Ts using this piece of equipment is more than sufficient to service any patient on a clinical study. So this gave us confidence to develop the CARD study at UCLH and the principal investigator is Professor Carl Peggs. And we're looking specifically at patients who have relapsed with CD19 positive disease following allogeneic transplant. Now, to date, at Great Ormond Street, 9 products have been made on this study. And what I would draw your attention to is that this is a study of multiple doses of CAR T-cells, and in all cases, the Prodigy was able to manufacture the doses required on study. Furthermore, the transduction efficiency was well above the minimal transduction efficiency set by our trial, which was 10%. And whenever you put the cells manufactured using this technology into a cytotoxicity assay against CD19 expressing targets, they can kill those targets also. So functionally, following this process, these cells are capable of performing an anti-CD19 role. And when we looked in more detail at the extended phenotyping, it confirmed the presence of central memory and non-exhausted T cells, which we all feel is very important in terms of delivering a product that's going to give you a durable response. And the clinical outcomes of this study will be reported at ASH later this year. Now I'm going to talk a little bit about the physiology, which I alluded to previously. So we wonder whether or not a more physiologic CAR targeting CD19 might result in better engraftment and less relapse. And we're looking at this in the context of 2 studies, one in kids and one in adults. And if we look at the current data, which has mostly come out of the United States, it certainly suggests that second-generation CAR T-cells are hugely effective therapies, resulting in unprecedented responses, certainly in pediatric ALL. But it seems that the CAR persistence is important, and certainly these CARs where there's very high rates of early activity, there seems to be a significant burden of toxicity, resulting in CRS in 30 to 40% of patients and 20% of patients suffering severe neurotoxicity. So, we screened a multitude of different CD19 binding antibodies in our laboratory, and following this process we identified one which we've called CAT, the CAT CAR. It seems to have a lower binding affinity for CD19 compared with the gold standard, which is FMC63. This is the binder used by all of the big pharma companies, and it's also been used in the Eliana study at UPenn. Now the CAT CAR has a similar on rate to FMC63 in that it binds CD19 similarly, but it has a very fast off rate. It comes off much more quickly. And in fact, it's only in contact with the target cell for 9.8 seconds compared with 21 minutes for FMC63. So the logical question you might ask is this sufficient time for the CAT CAR to be able to deliver an anti-tumor effect? Now, if you look at the CAT, it's very similar to Chimeric in its structure. It's essentially derived from the structure described by Campana et al. It's a 4-1BB CAR, again with a nod to persistence as one of the sort of linchpins of our program. And if you look at this CAT CAR in vitro, how does it compare to FMC63? Well, it's actually able to perform its cytotoxic function, the same as FMC63. And furthermore, it seems to have superior proliferation when it's in contact with CD19 positive targets compared with FMC63. If you look further, you'll see that there's reduced expression of exhaustion markers on the CAR-Ts in vitro also. And if you go into a mouse model, which is a very conventional model looking at the NALM6 CD19 expressing target in an immunodeficient mouse, an NSG mouse, and you then introduce your CAR versus FMC63 CAR T-cells into that model, what you see is that the CAT really controls the tumour very well, as can be seen on the graph on the right. This is illustrated by bioluminescence, so our tumour is labelled and is able to be seen by bioluminescent technology. So far with CAT, so good. Despite the fact it has a very short abbreviated time on target, it seems to be able to deliver a cytotoxic function both in vitro and in vivo, and perhaps has a greater capacity for proliferation. When you actually look in this mouse model further, you see that the CAR is able to deliver a bigger anti-tumour effect if you look in the bone marrow of those mice. What you also see is that the CAR T cells accumulate in greater numbers in the bone marrow and peripheral blood. So with this in mind, putting this all together, we wonder whether the CAR, because of its more physiologic binding kinetics, might actually improve engraftment and persistence. And because it's not in contact with the tumour for the lengthy periods that the likes of FMC63 is, can this potentially reduce toxicity? So as I said, we've got two studies running at the moment. One is CARPAL, a paediatric BALL phase 1 study run at Great Ormond Street by Sarah Garashian and Persis Amrolia. And then we've got the ALL-CAR 19 study, which is run at UCLH in adults and is run by Carl Peggs. And the CARPAL schema and design is very standard. I'm sure you're all aware that lymphodepletion seems to be a very critical part of the CAR T study design. It seems to increase the engraftment of your CAR Ts and potentially restricts or it improves persistence going forward. So certainly lymphodepletion is a critical part of this, the design of this study. And furthermore, there is one single dose of CAR T cells delivered at 1 × 10⁶ per kilo, and then the patients are very closely monitored thereafter for the engraftment of the cells and also for potential relapse. So the inclusion and entry criteria for this study are not controversial. This is for children and young adults with high-risk relapsed CD19 positive malignancy, those with predicted very poor survivals. And I think the thing that does maybe separate this study from others is the fact that there's no exclusion for patients with CNS disease, because as most of us clinicians know, this makes up quite a large proportion of the patients that are referred in to us for consideration of novel therapies. And there was no exclusion for prior use of blinatumomab, which of course people are sceptical as to whether this may compromise CD19 expression on blasts and potentially compromise the efficacy of CAR. So the first thing we can say about this CAR in vivo in a pediatric population with ALL is that there is excellent persistence of the CAR by qPCR. And if you look at the plots on the left is from CARPAL, the plot on the right is from the Eliana study from UPenn. And in CARPAL, CAR was detected in 8 of 9 treated patients at the last follow-up, and that was ranging up to 1 year. We actually have an anti-idiotype antibody that can specifically stain the CAR in the lab, and it's very heartening for us to see when we get patient blood during the treatment that you can see it very clearly expressed in the peripheral blood. And when you look at the responses, these again are very comparable to the responses seen in Eliana. So you've got some patients who really have done very well with sort of remissions lasting 12 months and beyond. The formidable problem here is CD19 negative relapse, as we would all expect from the Eliana data also. And the thing that really sort of distinguishes this study is the fact that there was really very little toxicity to mention. So CRS was seen, but there was no severe CRS reported in this study. No tocilizumab was administered in all of those treated patients. And you can see also the neurotoxicity, no grade 3 to 5 neurotoxicity reported. Cytopenias is another complication of CAR T that was noted in all patients, and in some of those patients it was reported beyond 30 days, which again is something we recognise from the literature as a phenomenon associated with CAR T. So if we were to summarise, we'd say that actually this seems to be a treatment that can work very well for paediatric BALL. It's delivered high rates of molecular response, and furthermore, some of those responses were sustained, including one patient beyond 2 years. There was a very low incidence of cytokine release, and CD19 loss was the commonest cause of relapse. There will be an update to this information by Professor Amroulia and his team tomorrow, with the abstract mentioned there. So ALL-CAR19, this is our adult equivalent of the CAR PAL study. And again, looking at this physiologic CAR, this CAT CAR, and we're also exploring the automated manufacture. So we're manufacturing these CAR T-cells using the Prodigy. The study design, again, is uncontroversial. It involves lymphodepletion of patients up front. There is a split dose CAR T administration schedule, and it is also titrated according to bone marrow blast burden, because as you will be aware from the data coming out of Fred Hutch, it seemed that reducing the number of CAR Ts administered to patients with higher disease burdens was associated with less toxicity. We've manufactured quite a lot of products on this study so far, and we've managed to meet the doses for all of those patients. In the red box, it's supposed to illustrate to you there's been a change in manufacture through this study, and within the red box, that's our Prodigy data. And I'd like to draw your attention to the fact that the central memory populations that we develop or that we're able to manufacture using this piece of equipment are really very impressive. And again, with the adults, we're seeing the CAR T cells by flow cytometry and even detectable up to month 2. And I'd draw your attention to the fact that this patient actually received high-dose steroids after month 1, and still these cells have persisted. So interim results from this clinical study will be presented at AACR this year. Now, I'm going to move on briefly to strategies for prevention of CD19 negative escape. Can simultaneous targeting of CD19 and 22 reduce the incidence of CD19 negative relapse? Well, essentially, targeting both of these antigens makes a lot of sense, and at UCL, we're not the only people to be doing this by a long way. The group at Stanford are using a TAN CAR, which is the construct in the middle, where you can see 2 single-chain FVs, 2 antibodies on the same stalk with the same signaling endodomain. We've got a slightly different approach where we've simultaneously expressing both a CD19 and a CD22 CAR on the surface of the cell, because we believe that CD19 and CD22 have such a size differential that we feel it may compromise binding if you have both of your 22 and your 19 binders on the one stalk. So this is the cassette that we're using for this clinical study. On the left, you can see a CD19 binding CAR, and on the right is our CD22 binding CAR. The CD22 binding CAR looks quite complex. It's a pentavalent structure with multiple signaling endodomains, and there was a lot of sort of preclinical work went into finding this optimal CD22 binder. Dual antigen targeting, we hope, will target the CD19 negative escapes that have been described. We've humanized the binders to try to reduce the immunogenicity risk compared with murine binders, and we're focusing mostly on OX40 and 4-1BB and not so much on CD28, because we're really our focus is more on persistence. And in fact, if you use this construct and we transduce or we introduce this gene into T cells, human T cells, you can see that you get equimolar expression of the CD19 and CD22 CARs on the surface of the cell. And in fact, this is now entered into a clinical study called Amelia, which is being run at Great Ormond Street and also at UCLH, and it's targeting a pediatric population. And at the moment, because this is a very novel construct, we've had to go sort of back to the very beginning and design this study as a dose escalation. And to date, the doses that have been administered to patients include the 1 times 10 to the 6, the 3 times 10 to the 6, and one patient with 5 times 10 to the 6. And so far, the data that's been looked at ASH at the end of 2018, they looked at data from 10 patients. And in terms of the toxicities reported, there was very little severe toxicity. So there was only one episode of greater than grade 3 neurotoxicity, and that was actually felt to be due to prior extensive treatment with intrathecal methotrexate rather than CAR. And as you can see, there was no grade 3 or more cytokine release syndrome. Now, if you look at the responses on this study, what we haven't seen yet are any CD19 or CD22 negative relapses. As you can see at the bottom of the slide, on the lower doses, patients were relapsing, but with CD19 positive disease. So it may well be that there is a threshold dose for efficacy on this study. But as you move up towards 3 times 10 to the 6 per kilogram, what you're then seeing is ongoing remissions, certainly up to 4 months, and in one case over 6 months, which are MRD negative. So these are deep remissions from their BALL. So if we look lastly at how are we going to approach off-the-shelf allogeneic CAR T-cells for our patients, for those for whom we can't manufacture, those who have been so heavily pre-treated with chemotherapy that autologous CAR is not a viable option, or simply just that we can generate a product that is much cheaper and much less cumbersome to make because we're making it for big populations of patients. So there are 2 approaches that have been explored at UCL, and the first one we'll talk about is the CAR T-19 approach. And essentially what this is a universal CAR targeting CD19. And instead of going to your patient, instead of going to an allogeneic bone marrow donor, you're actually going to a healthy donor who has just walked off the street. And essentially this patient, this healthy person, you harvest all their T cells and you introduce your CAR into those T cells to give to numerous patients. But of course there are 2 major issues with this approach. One is that what patients are likely to recognize unmatched third-party cells as foreign and potentially reject them. And the second big issue we've got is that if you've got a very immunosuppressed patient, there is the potential and the risk that they may not see the incoming cells, and the incoming cells will recognize them and deliver a graft versus host effect. So this introduces big risks with this as a strategy. So to address that, this approach involves genome editing, and I'll go into that in a bit more detail here. So essentially, on this program, what they're using is TALENs to edit out 2 critical parts of the T cell before they're introduced into patients. The first thing that is edited is the T cell receptor. And in doing that, it renders this T cell agnostic and unable to deliver a graft versus host reaction. The other target for this approach is CD52. And CD52, as we're all familiar with, is the target of Campath, which is a very potent immunosuppression agent, often used in transplantation. So that is also taken out of these universal CAR T cells. And the object is that you can then lymphodeplete patients who are about to receive this product with Campath, such that the rest of their T cell population is deleted, and the only cells that are spared that are the CAR Ts that you have introduced, and that overcomes the risk of rejection of these cells. In terms of deleting the TCR, as I've already mentioned, this is done with the objective of minimizing the risks of GVHD to that patient. And as you can see, the idea is that you make this in big batches, you freeze it down, and you just call up and ask for a dose when you've got a patient with relapsed ALL. So there are studies running looking at this at the moment. Certainly it's for relapsed and refractory BALL. There is some early data that's been published by our colleague Wasim Kasim in Science Translational Medicine, and there have been updates at ASH in 2017 and 2018. At the moment, the CI, the Chief Investigator of the Paediatric Study, is Paul Wies at Great Ormond Street Hospital, and in the adult study that's being run at King's College Hospital in London, and the CI is Reuben Benjamin. But we do have some questions about genome editing in general, because it's extremely complex to do, it's extremely costly, the manufacture process for these cells. There are a lot of really very difficult to predict risks associated with off-target events. The transgene integration, i.e. your CAR integration, which is done usually by lentiviral transduction, and the editing, they're not coupled. So you may get some CARs that haven't lost the TCR or the CD52. And the risk of introducing a TCR positive population into an immunosuppressed patient who's received CAMPATH that actually has a TCR and that can deliver GVH is a major risk. So we have another question. Is there a different way of doing this? To overcome some of the complexities of manufacture and the costs, can you deliver TCR retention via a simple protein engineering strategy? And we're doing that in the context of a study that's really the newest of our portfolio. It's called CAR 19. And the idea is that you essentially develop an antibody to target a component of your CD3 complex, and you attach a little anchor to that antibody such that it gets stuck in the endoplasmic reticulum, and it's there in its folded form and capable of binding those elements of the TCR that you hope to retain within the Golgi. And if you retain these important elements, and in our case we've targeted the epsilon portion of the TCR, if you anchor these within the Golgi and they can't get to the cell surface, then your TCR cannot assemble. And if your TCR cannot assemble, effectively you've achieved the same outcome as you potentially would have done with genome editing. And in the lab, Paul Machocha and Martin Pule have been very engaged with this project, and this slide is supposed to show you that if you introduce this gene for the Golgi retention signal attached to a CAR transgene, and you introduce this into normal T cells, what you see is that you downregulate expression of the TCR, as you can see by this this middle plot here. So this population of cells that are transduced do not express TCR. And if you then run this population of cells through a column, you select on what we have here, which is our suicide gene, you get a very highly pure population of TCR knockdown CAR T cells. And the CAR 19 it'll be a tri-cistronic vector construct. So essentially, it will have three major components. So one important component with anything that has the potential to deliver risks such as GVHD, we have to incorporate a suicide gene. This is the CAR, this is our physiologic binder, the CAR. And our last component is essentially our KDEL complex, that's our antibody that binds the CD3 epsilon chain. And if you use this or you look in vivo, what you can see is that the CAR T cells with the KDEL retention signal kill targets just as effectively as standard CAR at both doses of 2 × 10⁵ and at doses of 1 × 10⁵. And if you then put these cells into a murine GVHD model, what you see is that the KDEL CARs do not give GVHD to these animals. So essentially you are restricting the expression of your TCR such that these cells cannot give the animals GVHD compared with your control animals that have received standard CAR. So this is very promising. And in fact, the MRC have sponsored a phase 1 study of the CAR-19, and we'll be bringing that to clinic in Q4 of this year. Now, I've described to you our body of work that's trying to address all of the major issues that are faced in the CD19 space at the moment, and these are applicable to both lymphoblastic leukemia and lymphoma. It takes a small army of people to do the work, and certainly it takes a lot of benevolence and understanding from a lot of funders. So we are eternally grateful to all of our funders and our employees, and also to our patients and their families who submit themselves to our studies. And this is an overview of the current studies that we have running at UCL, and I'd be happy to discuss any of them with any interested parties after this talk. And I'd just like to say thank you very much for listening to me today, and do feel free to get in touch with me on that email address. Thank you.
Claire, thanks very much for a great presentation. I guess that there are several questions, so please. So maybe I can start. So in your NICE trial with the dual targeting CD19 and CD22, you described that you also had some relapses. So what was the reason of a relapse in the CD19, CD22 trial? Was it lack of persistence or?
Yes, I think that was the hypothesis. So those relapses were, without exception, CD19 positive relapses in the context of loss of signal by both flow and qPCR. So the question within the trial is whether or not that's a dose phenomenon. And, you know, as they go up the dose escalation at 3 times 10 to the 6 per kilo, they were seeing certainly less of that. And they've now gone up another cohort to 5 times 10 to the 6. But it's a very important point because clearly persistence in this population is critical. So we do have plans to take CAR and to try to sort of make a dual targeting strategy with it, because we feel it has, you know, this beneficial profile with respect to persistence.
Yes, please.
Very nice talk. I really enjoy it. As a strategy to get across the genetic manipulation of T cells, would you think that expressing the CAR-19 specifically in a genomic safe harbor using CRISPR-Cas9 would help?
Yes, like Michel Sadelain and his team over in MSKCC. I mean, there's no doubt that that's a really compelling program that they're running as well, with its own challenges. I'm not sure whether I think that is likely to deliver the sort of longer term persistence in the clinic. I'm a believer to some extent in anarchy, and the anarchy that's delivered by a lentiviral vector, and the sort of random integration of that lentiviral vector, you know, wherever in the genome. I think that perhaps that may deliver some advantages to some cells over others. So I think we've seen publications from Carl June where there's been disruption of TET2 and, you know, the delivery of a very sort of proliferative CAR T clone. So delivering things to safe harbors, unless you've got a very sort of clear strategy as to how you can sort of, with promoters, as to how you can sort of maintain that level of expression, I'm not sure. We'd have to see the clinical study.
Because you may agree that delivering the CAR in a safe harbor would, you know, avoid the fears we have about random proviral integrations.
Yeah, no, I do. I mean, I concur with that. But yeah, as I say, I have to be convinced. I'd need to see the clinical data first.
June, please.
So a comment. I mean, the comment is that the fear of integration is only theoretic. And I think there's been an asymmetric regulatory approach so that 5 to 10% of people getting the cytotoxic chemotherapy we get secondary cancers, and we're not required to follow them for 15 years. There's not been, with more than 1,000 patients treated, anyone get a transformation of T cells. So T cells are much safer than our standard convention, and we don't have a symmetrical regulatory health policy on this. So that's a political statement, and it's occurring both in the U.S. and in Europe. And your data was very nice. And what I wonder is, did you do a head-to-head comparison of the Golgi retention strategy with a KDEL compared to ZFN or tail and knockout?
So that's a program of work that's coming up that's sponsored by the MRC. So there will be concurrent lines of preclinical and essentially scale-ups to bring it into the clean rooms. So.
Yeah, have you looked at all, is there an unfolded protein response in those cells that have the retained TCR?
No, in fact it seems that the cells have sort of superior longevity, certainly in vitro and in vivo, and I know that that's a very sort of limited sort of go look see, but I guess we'll see in the patients.
Hi, Marisa Kirsten. Thank you, great work. I was wondering, I have a practical question. What is the rationale for split dosing if you don't see that much toxicity? Do you expect better extension?
So, yeah, I mean, this is the benefit of hindsight speaking. So I think there was a lot of fear delivered through various sort of abstracts in adults about the degree of toxicity we might see. And when we designed this study, that was our biggest concern. Because we're dealing with real-world patients. These are not sort of cherry-picked, heavily selected patients. These are, and so when we designed it, we felt that that was an appropriate strategy. Going forward, you're
Could
right,
amend it,
perhaps
yeah.
not.
Thank you.
Yeah.
Two more questions, Jakub.
Okay. Thank you for the presentation. Just a quick and practical question. What do you use to evaluate the expression of CD19 to be sure that your cells are 100% expressing CD19?
Sorry, could you repeat that for me? Just a bit deaf.
What test do you use to investigate or to evaluate the expression of CD19?
Oh, so on our clinical samples?
Yes, in clinical sample, yes,
yeah.
of
So,
patients, yeah.
I mean, well, so essentially, I mean, our standard tests are delivered by our hospital staff, and so they have a dedicated immunophenotyping panel, and they can. So essentially, it's the hospital that's delivering the processing of these samples.
Yes, my question is because we never get 100% expression. That's why.
No, and I think there's limitations in flow cytometry also, and the standardization. I mean, if we wanted to take it forward, we'd have to quantitate expression formally by quantibright beads. There'd have to be a sort of a formal way of assessing that, but we're limited by what the hospital's prepared to deliver. Yeah.
Last question.
Hi, I have a question regarding the CAT CAR. Is your CAT CAR better than the FM63 when you have low antigen? So you said the CAT CAR is as good as FM63, but will it work the same when you have low levels of CD19?
Yeah, so that's all been looked at in the lab as well, and it does. So in the context of low antigen expression, it does deliver cytotoxicity. It delivers its superior proliferation profile and the minimal expression of exhaustion markers. So overall, yes, it irrespective of because we had a model that was based on cell lines that we generated with sort of like limiting levels of expression of CD19, but the CAR was able to perform, as well as, if not better than.
I'm afraid we have to move on. So thanks very much again for an excellent presentation and a good discussion.